latencies are like 1 or 2 minutes because you're putting a tag on there. This is sleep onset and this is sleep offset. A human has to, you know, the machine will do it, but then you've got to go in and see if it's true. So you can estimate time in bed, you can estimate sleep efficiency, and you can describe the variability from weekday or weekends, although the standard report that was in the Actigraph system wasn't there. Ones that when we use them for research, we could create a custom report because we had fancy computer people that would help us with that. And you could, you know, tag something as a weekday or a weekend, and you could report that variability. But the standard report that you get with your clinical system doesn't do that. And then I would describe if there was a circadian disturbance. Okay, you ready to have some fun now?
Oh yeah. Oh yeah.
Oh yeah. Okay. Based on this actigraphy data, which of the following descriptions best fits this pattern? Now here is days, and if this usually will say the day of the week, we can't read it on here. And I'm gonna tell you the truth. I got these from the Respironics website, and so that's why I can't quite read those. But their pictures are really beautiful. So here's a week of data, and because you couldn't read the time at the bottom, I created something extra, and we're gonna see this pattern in all the other ones we're gonna look at. But here's noon, 6 p.m., midnight, 6 a.m., and noon. So we're looking at 24 hours. We are looking at 7 different days. And you can see how different waking activity looks compared to sleeping activity. And you know what? You can dial this, you know, just like I play with sensitivities when I read PSGs. So what I end up doing with this is I kind of set the waking activity to not peg out. And then you can see a nice contrast with what sleeping activity looks like. And you know, I could figure out where do you kind of have to set it. But again, like I do with PSGs and hypnograms, I would imagine myself talking to the families and showing them this actigraph, because remember what I called it? I called it a truth buster. And I would sit down with the families to describe this. And then I just want to point out, see right there? Can everybody see that? Mm-hmm. That was the device was probably off for a shower or, you know, or a physical activity. You'd say take it off. But I just want you to be able to pattern recognize. But see that? Very flat, nothing going on. It was off. Device was off. They're supposed to tell you that on your log, but they don't always give you the log. So what do you think about this? Just look at the times and tell me what you see. Is this advanced sleep phase, delayed sleep phase, irregular wake sleep? This is why I told you to go to the ICSP and look up all those things, or normal sleep. What do people think?
I'll say, yeah, I'll go with normal as well. I mean, generally.
And that was my decision. I think so too. Strong work, everybody. This is kind of what normal amount of movement is in sleep. And you might say that when people REM, you know, you're supposed to be paralyzed, but I think there are some more arousals and stuff in REM. Okay? All right. Mm-hmm. So this is our kind of framework. Let's have some more fun.
Ooh.
Based on the actigraphy data, which of the following descriptions best fits this sleep-wake pattern? Okay, everybody?
Irregular?
Regular.
Come on, guys.
I'll say.
What time
I'll say.
asleep?
I'll say advanced. No, because it's like, no, because it's. They're starting to shift on a daily basis too.
Be careful, Nishan.
Because in regular, you have to have 3 periods, and then the total amount should still be
All
3 sleep
right.
periods in a
And
24 hour.
what's the definition of advanced sleep phase? What time do these elderly people start to get into bed? And what do you see on this tracing?
So then
I got
2
the times
hours,
there for you.
2 hours prior to normal, like culturally accepted bedtime.
Socially.
What do we got going on here?
So generally around 7 p.m. or so, 7 to 8 p.m.
Yeah,
I would assume.
he
Yeah.
looked out. What time is he waking up?
He's waking up around like
He's waking
3
up
or 4, and then I think the morning bits just naps because he's like tired, potentially.
Yeah, yeah. So this is a great old person advanced sleep phase. This is going to show up on your boards, guys. Be prepared. Is everybody comfortable with that now that you sort of see it?
I think it's the bedtime part that kind of threw me off. Wait time definitely advanced.
Yeah. But what time do old people get up? They get up at 4 in the morning, right?
Mm-hmm.
Yep.
So that's how you, so how you do this, you've got to look at what time people are waking up. And that's why I mean, in your exam, you'll be able to actually read it. You can't in this thing that I put there. That's why I put the times there for you. Okay. So that's your clues. All right. Ready for more fun?
Let's do it.
Based on this actigraphy data, which of the following descriptions best fits this pattern?
All right,
Somebody
now
tell me
pretty
what
comfortable
you
with it.
see. What time is the person getting into bed and what time is the person waking up?
Maybe delayed.
Could call this delayed.
Yeah.
So getting into bed around 2 a.m. or so, and then getting up, I'm on average anywhere between
10 to 12.
10 to 12 in the morning.
Yeah. So you looked at the wake
The
time.
first top 2 days could potentially be the weekend, or he probably slept ad lib and slept a little longer, but it looks like a delayed.
Yeah. What time's the person going to bed?
Say around 2 to 3 a.m.
All right. Strong work, everybody. You will see something like this in your board exam. All right. Ready for more fun?
Yep.
Based on this actigraphy data, which of the following best describes this pattern?
This is like non-24.
Mhm.
Around there, right?
Yeah, somebody will show you this. Everybody's good with that?
Mm-hmm.
Do they ever not fit that pattern nicely where where they don't go around the carousel or around the clock? They sort of advance, have a delay, and then do they ever not complete that circle?
That's interesting because there's a guy that used to give a talk and he'd show this and he said, because there are some teenagers that kind of are oppositional and then there's a sudden flip, they just stay up later, and they don't really they're not really truly non-24, but they're choosing these things. So anyway, and he believes there's a behavioral element to some of those people. So that when you ask that question, Moshe, I think that's a possibility. There are some people that I'm staying up later, and then I jump, and it's not really a circadian non-entrainment problem. It's more behavioral. Okay. Based on this actigraphy data, which of the following best describes this pattern? This one's tricky. So Use all your powers of observations. Think this
This was
one
the
very
nurse
carefully
taking
through.
4 shifts in a row, maybe. Nice.
Yeah, that's
All
possible.
right,
Yeah.
got it?
Mm-hmm.
Yeah. What time is the person working? What time is the person busy and active and not sleeping?
Well, then they're working
And
like third shift type of thing, like
yeah.
Third shift.
o'clock to like
And
7
then-
o'clock in the morning.
And then they sleep
being a hot
18 hours a day.
Yeah, trying to catch up and then trying to hang out with their family. Okay,
Mhm.
I just want you to be able to do the pattern recognition. Okay, ready for more fun?
Mhm.
Yep.
Oh.
What is this?
A hibernating polar bear.
I'd call it, yeah. It seems more
Imagine-
irregular.
Yeah, the problem with this one is I think they haven't cranked the sensitivity up enough. So if you can imagine this blown up a little bit,
Mm-hmm.
but think about a nursing home and a demented person.
Right.
Mm-hmm.
Just, sleep, wake, it's just a lot of sleeping. So this is a sort of a classic. It's got, most of them have more than 3 sleep periods.
Right.
They could have a movement disorder, but just think about somebody in a nursing home just kind of, not really having a pattern. Okay?
Mm-hmm.
All right, ready for more fun?
Yep.
Which of the following diagnoses best fit this pattern? So sometimes the strategy for board exams is read all the answers and then imagine what the actigraph would look like.
Mm-hmm.
That's a big clue.
So it doesn't, generally,
Look at the diagnoses.
definitely not a hypersomnia. It doesn't seem like a good amount of sleep time. Normal sleep, it doesn't fit any rhyme or reason to be called a normal
You're
sleep.
out.
I think this person has sleep onset as well as sleep maintenance insomnia.
Right.
It crashes.
Okay, so you just learned how to strategically do board exam questions, because this really doesn't look like hypersomnia is out because there's not too much sleep. This is not normal.
Mhm.
And then think about what somebody complains to you with insomnia, and this doesn't look circadian,
Mhm.
The only thing you might mess up, and I didn't make it a choice, was the irregular wake sleep.
Right.
But I didn't offer that as a choice. But think of your insomnia patient and you didn't believe them. Now you believe them, right?
Right.
Mm-hmm. Mm-hmm.
Okay. More fun?
Okay.
Okay. Based on this one, what best fits? What time do they go to bed? What time do they get up? Look at the
Midnight to 6.
activity. Look at the
Insufficient sleep, say.
Yeah, I'll go with A.
Really?
Midnight to
Maybe that's because I have this over too far. Here's where midnight really is.
Oh, okay.
Okay.
Bad, Carol.
And then I guess it would be normal.
All right.
Yeah.
Way to go, guys. And
But also you
take a
can't.
nap. That's what a nap looks like. That's actually one of the reasons I wanted to show you that.
So would option C and D ever be correct on actigraphy?
No, I put them as bad choices. If you see them,
They,
throw them out. I specifically did that because what did I tell you in the beginning? What can you not diagnose with actigraphy?
PLMD and sleep disorder breathing.
right.
Yes. There's a method to my madness here. Okay, more fun?
Yeah.
Want to have more fun? Okay,
Ooh, double.
watch out for the double plot. Does anybody know what I'm talking about?
Nope.
It's good we're doing this talk. They will show you a double plot. Yeah! So what do you see here? Tell me what you see. I'll walk you through it.
So
It's not fair. Okay, here we got sleep, right?
Mm-hmm.
We probably have sleep here. Activity,
Right.
inactivity. This is midnight, midnight, midnight. So this is one day, this day. In the double plot, this one moves over here. So this whole segment is now over here. And this was an older way of displaying things. And it was nice because you could see the free running really easily. But this is this, this is this. See how they're repeats? Actually, the newer
okay.
software doesn't even show it. But this shows up on board exams. So I didn't want you to get messed up on your exam if they show you a double plot. So you just gotta kind of use your powers and see asleep and awake. And this is actually normal sleep, right?
Right.
Because there's
Yeah,
somebody
right.
sleeping from midnight to 8 and then they're active. And then they're sleeping here. So is everybody good on this one?
Yeah.
Mm-hmm.
Okay. Now this one, this is a delayed sleep phase, but you probably can't see that because you can't see the times up there. But they won't show you one that you can't read. They'll fix this up here. But yellow is there's light, but you just can't see the times here. If you could see the times, you could know this is somebody who's got fixed delayed sleep phase.
Now, is delayed always, or not always, but is it more obvious? Like in the ICSC, it says 2 hours after normal or culturally accepted bedtime. So, is that
They'll make it
defined?
really obvious.
Like
So
2
here's,
a.m. or something?
here is night. That's your clue. And I don't know if night's like 10 to 6. See this day, night,
Right.
day, night. So here is somebody kind of sleeping mostly during the day. That could be another clue. And that's really shifted. Okay?
Yep.
That might be a way to figure it out. And this is how free running looks. And that's why people like double plots. And I swear this has shown up on board exams multiple times. Okay. Now, I showed you pretty pictures. You want to see what, do we have enough time? We got started a little late, but are you guys good for looking at more stuff?
Yes.
Sure.
Yep.
Okay. These are real Carol cases. This is a 19-year-old with ADHD and complaints of insomnia. Now, I didn't show you this before, but we had the Respironics. This was the not Respironics. It was another company and I'm blanking on their name. And there's their light, the ambient light, movement. Green is there's too much activity and the algorithm called it resting. And blue is the algorithm called it sleep, that this was more likely to be sleep. But that's what those different colors are. And you can see the person probably had the TV on right there because there's low light, and then they turned the TV off, or they got under the covers and you can't see the light anymore. You see that? Ambient light, maybe TV light, maybe jammies on, and hand and device under the covers. Everybody good with that?
Mm-hmm.
And then waking up, lights are on, activity. And red is the machine saying these epics are more likely to be wake. I think I used the diary to assign the colors because I edited this. Here you can see not much activity, but here, or maybe the guy told me he was sleeping, but he may not be sleeping. This is the real truth about actigraphy and how difficult it is. So you get a summary statistics from your algorithm, and see there's a min and a max and an average. So here is the minimum bedtime, or the average bedtime is 10:30, the average wake time is 6, the average hours in bed was almost 11 hours based on what the guy told you. What was his total sleep time? So horrible sleep efficiency for average. And then here's the worst, and that would be where there was no real sleep during the sleep period. And the best was 6 hours. And so what would you end up saying about this? You know, because this guy, his story sounded so pathetic. I thought, yo, you can't really be that bad. But you know what? He is that bad.
Mm-hmm.
Everybody kind of comfortable with that?
Sure.
And then he took the watch off. And he actually did this for 2 weeks, and he just quit trying. And his logs were terrible, but he was so pathetic. It was really sad. He had just terrible life problems, and he was miserable from his insomnia. So he was as bad, because here he is just laying in bed, not sleeping during the day. Okay, so what diagnosis do we want to make here? Could we make here? Well, actually, I changed the question. Which diagnosis is inconsistent with his clinical scenario?
Hypersomnia.
Very good. Because he probably has everything, right? He's got a biological clock disturbance.
Right.
He's got insufficient sleep, and he's got chronic insomnia. You could make multiple diagnoses here. All right, ready for more fun?
I just have a question
Yeah.
to that. If you're calling it biological clock disturbance, and it seems like he's a delayed type of person, potentially falling asleep around 12, 10:30 to 12 o'clock, can you call it insomnia if you're labeling it potentially the biological clock disturbance? Because is it insomnia based off the fact that he's trying to go to bed at a socially acceptable time and you can't?
He's laying in bed not sleeping. He's got sleep onset problems and sleep maintenance problems. But also his habitual sleep onset time is late, and then he tried to stay in bed all day. You could argue about this, but his brain doesn't fall. You know, what might be one of the things you might do? You might be do stimulus control and say, don't lay in bed because you're habitually falling asleep late. Get in bed closer to the time your body's falling asleep. I didn't call them delayed sleep phase. I'm just using, there is a circadian piece. And you know what? In insomnia, a high percentage of those patients have a circadian issue, and that's why you do stimulus control or bedtime fading.
Right. Okay.
All right, so this is the Respironics brand that looks different. This was a 15-year-old with trouble sleeping. She was falling asleep in class. She was tardy for school, and she had ADHD. What do you see? Tell me what you see. What time is she habitually falling asleep?
2 a.m. or so, usually.
It's all over the place, isn't it?
Right. Yeah, generally between 12 to 2-ish.
There's not really a good average, is there?
Mm-hmm.
How many hours of sleep is she getting? 1, 2, 3, 4, 5. This is her telling me she got out of bed. If you believe that. So these are the event markers. It's all bullshit, you know? Look at, I mean, these are our patients, right?
Oh.
You see all the event markers? You're supposed to click it when you are get into bed or, yeah, you know, get out of bed.
But
Did she really get into bed?
So she can't really control touching the event marker.
She's an event marker button pusher. And she doesn't tell the truth.
Right.
Here's where she said she got out of bed. She probably got out of bed here and then forgot to push it until there.
And the area on the graph where there's like a red underline but no black markings that's marked as awake, is that because the device was off?
That's the device is off. And some of the auto scoring will grab that correctly. Sometimes you have to put it there. But you're right. That's a good point. And here, she's got enough movement that the device said that she's likely to be awake, but it looks like a nap to me. And in fact, if there's, you know, or actually this one is different. Red is where it's sleeping. And then this red is the device is off. So you get to color this in of what you want to be included in sleep. So if you don't color this in because there's nothing there, I mean, that's just not what real sleep looks like. It'll go into adding of your 20, because it'll give you in a 24-hour period how much sleep you had. So sometimes she's getting plenty of sleep. Like here, she slept from here all the way over here. But that's because she only got 6 hours or 5 hours here. And here, 1, 2, 3, 4, 5, 6 hours. And then she slept long here.
And how do you distinguish between the time the device is off and sleep? I know that sometimes it can be confusing.
You should have a little ditzels.
Mm-hmm.
You need a little noise. If it's Zippo, it's probably off.
Got it.
Zippo and ditzels. That's very scientific.
Sure is.
Okay, so here's my question. Which diagnosis is inconsistent with this teen's story?
Say hypersomnia.
Yeah, because what do you have to have for hypersomnia? I mean, most of her longer sleeps are related to
It seems like, yeah, it follows a short night of sleep and she kind of catches it.
So she's got lots going on. She's got lots of Michigan.
Mm-hmm.
Okay. Are you ready for more fun?
Why wouldn't that be insufficient sleep? I mean, if she has total in 24 hours, she looks like she has.
Which one is inconsistent? Inconsistent.
I see. Okay.
Yes. So insufficient sleep is, you're right. That's one of your things that she's doing sometimes. She's got chronic insomnia, which is sort of fake. She's got delayed sleep phase and insufficient sleep. And she has a Z code, probably inadequate sleep hygiene, but you don't get paid for Z codes, right? Okay. So here's another brand of so the red bars are waking, and then these are epics where probably awake. But to tell you the truth, this is probably something I put in. This one looks like the thing fell off, although there's two little marks there. I mean, you can kind of make it look whatever you want by turning up the sensitivity. But tell me, this is a 15-year-old who says, I am really sleepy. I am exhausted all the time. So I want you to look at the time this person gets into bed. And this person was a model citizen. Look at this. Please push the button when you get into bed. Please push the button when you get out of bed. Damn it, he did it right. Look at that. Then I also asked him to push the button when he had some irresistible sleepiness. Here's a nap. You see that? And he actually told me he took a nap. This was a great patient. Most of my patients are not so reliable. Okay, here's a question. Based on these actigraphy data, which of the following diagnoses would you be most concerned about with this actigraphy data in this story?
Poor kid needs more sleep.
Yeah.
B.
Sleeping
Oh, come on,
about 6
guys.
hours.
No, he's not.
Central hypersomnolence.
Very good. This is an actigraphy before his PSG MSLT. He had horrible narcolepsy.
But he's sleeping like 7 hours a night, though.
No, he's not. Here's
It
12
looks like
midnight.
12.
Here's 6 a.m. He's in bed at 10, and he's got irresistible sleepiness during the day. And he has to get up for school, but he's in bed at 10. Here's midnight.
Oh, okay.
And he's got naps. It's a little tricky, but not that tricky. Okay?
Yeah.
Is everybody with me?
Makes sense.
Yes.
Yeah, it makes sense.
And maybe he's got a little sleep fragmentation, a lot of red dots with his fragmentation with his narcolepsy. This is a good one for narcolepsy, and it actually was a real one. Okay. All right. This 19-year-old is tired and he's unconscious during the day. What do you see? Take a look, and then I'm going to ask you a question. His mom says you can't wake him up. He's unconscious. Based on these data, which diagnosis would you be most concerned about for this unconscious teenager?
Delayed.
All right.
Delayed.
Awesome. And you can see he was pretty good about telling the truth. That's him pushing his event button. And he mostly pushed it when he got out of bed. Everybody good with that? Here he got into bed a little earlier, but there was so much waking, I didn't move him over here. He might have been watching TV or who knows. I mean, there's some judgment here. I could have argued to put it here, and then he would have had reduced sleep efficiency. Okay? All right, very good. Now we know why he's unconscious, right?
So these are the kids that come to clinic and the parents say, I had to take him out of school because he can't stay awake. I had to homeschool him, like pour water on him, he don't wake up. Okay.
Yeah. That's why this is a truth buster. Okay, ready for another one? 14-year-old complaining about excessive daytime sleepiness. He has trouble sleeping, he has daytime sleep attacks, high anxieties on methylphenidate patch. It's actually she. Parent has requested that I get them school accommodations for her daughter's sleeping disorder. I can't get a story out of anybody. And you know what? They could not fill out a sleep log. Well, part of it was mom was in a wheelchair downstairs and she and her sister were upstairs getting into mischief. Okay. So tell me what you see. How good is she at pushing her event button reliably?
Not very good.
No.
Not very good. So here, I didn't mark sleep because I think she took her watch off, but I can't be sure. But this to me looks like watch off. This looks like watch on.
Mhm.
Do you see the difference?
Right.
Yeah.
And what do you think about this? Party time, dancing all night. Crash and burn. I think they stayed up and did hair at night. I think that's what was going on. I think they just partied at night. Okay, here's my question. Which diagnosis is inconsistent with these actigraphy data?
Inconsistent.
Inconsistent. What is not seen here?
I'll say advanced would be the most.
Because her fake advanced stuff is really her napping.
Yeah,
from
it's just
not.
really right. Yeah, it would be. I'll go with advanced.
Yeah, I don't think.
All right. So these are real actigraphs from real people. And they're not as pretty as the other ones, but there's some great stories to tell, aren't there? Okay. All right. Which diagnosis is most consistent, week 1 and week 2? What do you see?
Is this more like 12 a.m.? It's hard to tell.
So 12 is right here with this line right here.
Okay. Gotcha.
Well, it feels to me that it's not insomnia.
Right.
It's not advanced. And it's also
1, 2, 3, 4, 5.5.
so I think it's C by the process and limitation.
4.
Yeah, agreed. Insufficient sleep.
All right. Way to go, team. Okay, ready for some more? I got a few more. We still good?
Yep.
9-year-old with early morning waking. What's the diagnosis here? Is he depressed? The device is probably off here, and it's probably off here. He probably forgot to put it on and then put it on and push the event button. So he probably really was asleep over here. I just didn't draw it in, but I probably could have.
This looks
I'd
advanced.
say no. Wait,
How many
6 a.m.
9-year-olds go
Yeah.
to bed at 6 o'clock, 6 p.m.?
His parents never adjusted his bedtime from when he was an infant.
Yeah.
Actually, Mom has a similar problem. So I don't see many of these, but the big complaint was because he gets up in the early morning and disturbs his brother, but you can't keep him awake much past 6. And there are other family members with this.
Will this
I
be
think
someone who you
advanced
might?
phase. Yeah.
Will this be someone who you might use melatonin in the morning to pull the clock?
Oh, I think I might have tried it, but you know, the data isn't very good for that treatment.
Right.
But it's in the books.
Right.
I mean, I tried to turn on the light and keep him busy. This is really hard, but I think they've got the advanced phase SNP, this family. Okay, where can actigraphy mislead you? When you read these things, don't believe everything that's in the algorithm. That's my message to you. Okay, so we did a research project and we collected data on kids with asthma and stuff. So what do you see here? And the answer, I'm going to just tell you the thought process here. This person had snored to beat the band, lots of OSA symptoms, but look what the actigraphy looked like. I think the sensitivity is too high on this one. I probably would have cranked it down because almost, hitting the top here. So this looks a little bit, but when you got bad OSA and you keep waking up and moving from snoring, so that's probably REM, and the movements of bad OSA. So that's why you don't want to do it, because it looks like he didn't sleep at all. He probably did sleep, not very well, but that's what OSA looks like on an actigraph. This one, this is the opposite, where red is sleep and not red is waking. And this person had lots of complaints of being hypersomnolent and difficulty waking. And this person was eventually diagnosed as idiopathic hypersomnia, but they were in this asthma study, but this actigraph actually led to supporting that diagnosis. Everybody good with that? Some nights there wasn't all that much sleep here because they probably had to get up for school. This one, they probably didn't get to school because they were so tired. This is somebody, so I don't want you to say that this person can't sleep. If the story is, and this person had a classic narcolepsy story, you get this actigraphy. What you don't want to do is say, oh, you're watching TV all night, because this is the sleep fragmentation of narcolepsy. So you always got to clinically correlate things. Nobody's going to show you something this subtle on a board exam, but it'll happen to you in real life. And you know what? Well, we'll come to that. But I just thought this was really amazing. So when you have the sleep fragmentation phenotype in narcolepsy, don't say, oh, you can't have narcolepsy because you're not sleeping at night. You're fooling around. This person wasn't fooling around. Okay. This is an example. You know how we sometimes get asked to do impossible things in sleep clinic? Usually by neurologists or psychiatrists. This was a 23-year-old with tuberous sclerosis, intractable epilepsy, severe cognitive impairment, lives in a residential facility. And the facility says, some days we can't wake her up and she doesn't participate in activities and she doesn't get up to eat. And could you do a sleep study on her? It's like, no, I can't do a sleep study on her. I mean, because she had limited ability to cooperate with a procedure like that. But we did actigraphy. And I thought it was kind of interesting. I mean, the facility was right, but I'm not sure what I'm supposed to do with this person. And I think the question from the neurologist is, when her seizures are really bad, is that when she sleeps a lot or is that when she's awake a lot? I don't know. I'm not going to do a full montage on somebody like this in the sleep lab. Our staff can't manage somebody like this and do a study. But I thought her actigraphy was pretty interesting. I mean, this is bad brain, very bad brain. But she does have times when she can sleep, and then sometimes she can't sleep. And I can't tell you why that is, but I made a pretty picture of it. I think this is my last case. This was a teen with long-standing excessive daytime sleepiness. And he's 14 years old at this point in time, and his Epworth is 18/24. And I think I was thinking about doing a PSG MSLT, So I had actigraphs at this time, and so gave him an actigraph. It's kind of interesting because the device, you know, he says I got into bed, but the device says there's too much movement to be asleep here. I don't know if that's an algorithm problem or what it is, but the algorithm said this is wake and this is where I put sleep. So this wasn't easy to score because I'm the one that ends up assigning these things, but I guess I could have put it here, but then the sleep efficiency would have been much lower because it scored all this as potentially not sleep, as looking like waking. I mean, there's some things you can do to manipulate this. Here's where the device was off and probably just sitting in one place because you can see there's not much variation in the light threshold. But what's interesting here is if you look at the summary statistics that the algorithm, the non-human algorithm gave you, it said on average, his bedtime is 11:21. He gets up at 9 o'clock. He is in bed almost 10 hours, but his sleep efficiency is terrible. It's like 76%. So you might say, oh, you must be really sleepy because your sleep is so fragmented. That's the data you got from this actigraph. Although it doesn't actually look like that, but that's the data from the actigraph. So you have to decide if you want to believe it. Here's wake after sleep onset. It says on average, during your night, you are awake for 90 minutes. Well, no wonder you're sleepy because you're not sleeping at night. Although I have to tell you, this kind of looks like sleep, but that's what the machine algorithm said. So I did a PSG and MSLT on this guy for a lot of good reasons. His sleep latency was 2 hours. Damn it, they didn't take his iPad away. The staff. I don't know why they do that. He had a little snoring, a little flow limitation. His apnea-hypopnea index wasn't very long. But his sleep maintenance efficiency was 97%. So when I could really see the stages, when sleep was measured, not movement, look at that. What was all his other stuff? He had normal REM latency, a normal arousal index, no excessive limb movements. And you might think he might have had that based on what you got from actigraphy. His mean sleep latency was 17 minutes. He slept in one nap, which was nap 1, had no SORMs. So I didn't know what to do with him. But I couldn't diagnose him with a central hypersomnolence disorder. He came back about 3 years later with the same complaint. And still high Epworth. I redid his PS, because sometimes you don't get the diagnosis right the first time. And he had an OHI about 3.7, but this amount of sleepiness is way out of proportion to that. And all of them were post-movement. His REM latency was short on this one. He was in bed for almost 9 hours. He did have increased brief wakings and increased state changes. Arousal index wasn't that high. But there's his mean sleep latency from his MSLT, 14. He did fall asleep 3 times. He had 1 SORM on nap 2. And at the end, we gave him permission to have late school start times, and he could sleep about 9 hours. And his Epworth went way down. I'm thinking this guy's a long sleeper, and the early school start times in Cleveland just didn't work for him. And once his later start times were accommodated, he was less symptomatic. That's my best guess about him. But you could see where the actigraphy would have led you in another direction. And when you measured sleep, it was really very different. So Anyway, more than you wanted to know, but I think that will get you through your boards and will help you with your pattern recognition. And I think the times are changing, and this whole thing's going to change to consumer wearables in the next 5 years. Because these, you know how much they charge for those actigraphs? $900, $750. You don't get reimbursed. You have to do it yourself as a physician, unless you have somebody you can control the lab and make the staff do these tasks. Anyway, I had like 20 actigraphs in my heyday, and my patients lost them. Their dogs ate them. They didn't return them. They broke. And I didn't have any more Bank of Rosen slush funds, and I gave up. Because we used to do this with the fellows. I used to be able to teach you how to read them and stuff like that. And now I can't do it because we're all out of them. They're all broke. And I'm not going to spend any more money. Anyway, so that's my
getting reimbursement at all?
Huh?
You had no luck getting reimbursement from all kinds of insurance at all?
Are you kidding?
Oh, because it seems like Metro is still doing it, and then I asked them about the reimbursement, and then it seems
Well, ask them. Yeah, what did they say? Medicare actually will reimburse. So I don't know if they're doing them, or are they just doing them as good deeds? That's a good question. Who's at Metro?
I'm sure it's a
I am.
But I asked them that question 2 months ago when I was there. They were still doing Actigraphy for the time.
Do they replace their actigraphs? Do their dogs eat them? Do their patients lose them? Do they make them? I can't tell you how many patients, you have them sign that they're responsible and you get credit card information, but I never went after anybody, because I would go after rich people and not poor people, so I couldn't do that. All right, any questions about what I talked about? Your tank should be full.
Thank you.
Thanks.
Thank you very much. This is great.
That was really good.
So you don't have a clinic next week either, so we'll be the week following that, and we'll see.
I think the week following is Christie's clinic.
Right, but the second week of May. Anyway,
Yes.
when the time comes, we will see. We'll get the DV thing first.
What?
The dividing the patients with fellows.
Oh, yes,
Yeah.
thank you.
Mhm.
And then I think I'm gonna probably, Kingman asked me to do another session about
Implementations.
instrumentation. Okay, so I'm working on that presentation.
Thank you.
But you should be good to go with your actigraphy now.
Perfect. Thank you so much. Bye.
Bye-bye.
Thank you.